right. Thanks everyone for being here, and thanks so much to our guests for being here to this Egenis seminar, which is also going to be the last Egenis seminar I actually get to host as somebody who's still fully employed here. So I have to say, particularly a memorable occasion for me, at least. And so today we have two guests, not just one, which is absolutely wonderful. And we are in the space of medicine writ large, and also something that makes me particularly happy. We have a lot of history going on today, as well as philosophy and social studies. So as usual, speakers that are really speaking to a lot of the things that we're doing in our center. So we have Noortje Jacobs, who both of them actually from the Erasmus University in Rotterdam. Noortje Jacobs, who does work in the history of medicine and the history of science. She has a fantastic project that she's doing at the moment, a very prestigious project within the Dutch context called Value in the Body, where she's looking at the history of bodily materials in the 20th century, which is something that intersects with so many things going on at this center and that have been going on in Egenis over the years. I cannot even begin to list them, so I can't wait to hear much more about that project in the hours to come. And she's also been working on research ethics and what we mean by research ethics, particularly in relation to biomedicine and bioethics in an historical sense. So she has published a book that looks at the history of research ethics in the last century, which just came out in 2022, called Ethics by Committee, a history of reasoning together about medicine, science, and society, with Chicago. And so again, like a really important contribution, because that's a topic that comes up, I would say, every two seminars here in one way or the other, though people approach this topic from lots of different directions. And our second speaker is Martijn van der Meer, who I had the pleasure to meet now a few times, mostly around the Netherlands. So Martijn is doing his PhD with Noortje, and I think within the project, right? Is it formally within the project or not? Not because you have your own families. So, in relation to these issues, in the history of science and medicine, and particularly looking at the history of public health, which is particularly important for us all, because it brings together so many different dimensions what we do. And on top of doing this PhD that we're going to hear about very shortly, and those of you who came to the yearly meeting already discussed, Martijn has been, in fact, for many years active as a senior policy advisor for research policy, and in fact intersecting with some of the stuff that we do in open science, and also is the founder and co-editor still of the Journal of Trial and Error, which is one of the coolest initiatives in academia, I would say, all by early career researchers looking at what does it mean to publish negative results or results that actually don't seem to make much sense, or turn out not to make sense, even if you really thought that that would be the case. And so that's a super fun initiative that I would recommend you have a look at if you've never had a look at it. And in fact, also considering submitting to it. And this I just discovered by looking at your page. Oh, this is so cool. In the last year, you guys got mentions as the top coolest people in research under 30 from Forbes because of this, which is pretty great, actually. I've got to say congratulations. Anyhow, so the floor is to you, and we look forward to a presentation.
So Martijn is actually a global leader, which is very embarrassing for him, because we now constantly call him global.
I'll pick up on this. Probably no.
So we really make it, which is why we say it even more. Thank you so much, Sabina, for this nice introduction. And indeed, well, I think most of you we've met already when reading the paper just before this paper, which is about to be published in the European Journal for the History of Medicine and Health, with the title "When Infant Mortality Was Born, Dutch Preventive Child Healthcare Without the State," which we will talk about a bit more today. And these two papers on the rise of preventive child healthcare in the Netherlands, they combined are the first part of Martijn's PhD thesis on the history of preventive child healthcare in the 20th century, in which Martijn is particularly interested in how collective action, which we will talk a bit more about what we mean by that, may come to be. And what that looks like, and I cannot take credit for this because this is what performs me, is
just use a mouse. So just like click on the slides and then use the.
No, it's like, it's just kind of, oh, there we go. No, there we go. Thing two is that preventive child health care in the early 20th century looked like this. I think these are pictures from 1935, if I'm correct. 34, sorry. And this was the district nurse that we talked about in the session before. She traveled around by bike or by motorbike sometimes, in which these mothers increasingly in collectives, they in sometimes in pubs or in coffee houses, they came to have their children being weighed. Is that the way you pronounce it in English? Weighed. Yeah, sorry. Here the same thing. They did that as a group so they could watch each other participating in this. They got schooled by physicians. I don't think we have the picture on here from that, but physicians would increasingly in school rooms teach them that they would really have their child suckle at the breast. And then these nurses also came to visit these mothers at home to induce them to visit the clinic, which we will talk about. And also this started as an initiative that was locally in The Hague in 1901. It was just then in one district in The Hague, one clinic, but very quickly this became a practice all over the Netherlands. First, this is a picture from 1917, to major cities in the Netherlands, but then I think this Martijn is 1932. By then, this was organized all over the Netherlands, not always everywhere in the same way, but in very similar ways. But this was mostly done without central coordinating government. So this was not something that the central government, which actually does house in The Hague, thought up and then came to implement all over the Netherlands. This was something that was organized bottom up by different collectives. And in today's talk, we will explain how that came to be. The reason is not, at least that's what we put forward in this paper, why at the beginning of the 20th century did everywhere in the Netherlands people start to organize these clinics to prevent small children from dying, because maybe, I'm not sure if I've said that already, why did these clinics emerge? What did they do in practice was to investigate children, to weigh them, to look whether they were doing well, but mostly to give these mothers advice how to feed their children in order to prevent them from dying. Well, why did that happen at the beginning of the 20th century? A very intuitively logical answer would be because a lot of children were dying. But that's at least what we put forward was not necessarily the case. At least children had always been dying in what we consider today to be very large amounts, but actually from roughly the 1840s onwards in the Netherlands, less and less children were dying every year. In fact, around 1900, when the first child health clinic emerged, it was considered that it was only 1 in 4 still, or even less, which at the time was a historical low, although it would continue to drop. And by the time that it was everywhere in the Netherlands, it was then here, it was actually quite low. But what also happened in the same period is that infant mortality as a concept emerged in public discourse. As in Dutch you would say zuivelingssterfte or kindersterfte, which we translate as infant mortality. If you scan, which is possible to do these days, all newspapers in the Netherlands at the time, both regional and national, for these, the wording or the use of these words, it actually around the turn of the 20th century, you see an enormous peak. And so all of a sudden, before the children dying was hardly mentioned in newspapers at all, but around this time, this seems to be is becoming a big public problem, a word that we use after pragmatist philosopher John Dewey, which Martijn will talk about later, why we use that wording in that way. So we have asked a question in this paper, why around this period did infant mortality come to be perceived as a public problem? And we put infant mortality in between brackets for a reason, because we argue in this paper that in this period it came to be understood for the first time as a thing in and of itself. So no longer you had a lot of children dying, but you had such a thing as infant mortality. And that was something different, something new than what had been there before. And then that's the second question. So this perception, and for us therefore also perception is a very important word. We're not interested so much in the thing in and of itself, infant mortality, but the perception of infant mortality as a public problem. What consequences did that perception then have in terms of collective action? Collective action, that's a term we use after a historian, medical historian, quite famous in our field, but maybe also with some of you, Dorothy Porter, who says collective action for her is collective action in relation to the health of populations. Is that the right translation?
Well, that's the definition of public health.
Public health, thank you. So public health is collective action in relation to the health of populations. And why we really like this understanding of public health is because it allows us quite often in the literature on public health, among historians, but maybe also among sociologists, that would be interesting also to discuss, when the term public health is mentioned, quite instantly you go to public, to state, to central governments. Whereas for her, studying historically public health as collective action is an advantage of two things. The first one being that there is this emphasis on action, that public health in this sense is then understood as doing things together and not necessarily the institutions that you have for doing something, but the activity itself. And also an emphasis on populations, that you need to have a population within view that then this collective action is directed towards, which then is also something, which for us as historians is very interesting, that can change through time. The way who or what falls within the realm of public health, who or what is understood to be a population, is not something that has historically always been the same. And with that, something that we will argue later on, is that if, for example, your definition of a population changes, your collective action might also change. At least that's something that we think in the history of preventive child health care that you see happening. And just a small glimpse that when the first child health clinic came up in the Netherlands, the population at risk was still understood to be working class people within bigger cities, whereas 30 years later, it's actually understood to be Catholic people in the rural South. And with the changing of the population, you see also changing collective actions, changing ways of doing things together, and the end result there is then public health. Right?
Yes.
Okay. So in this talk, we will show that a rise of collective action followed from the recognition of infant mortality as a public problem. I will say a bit more about that. And then I will give the baton on to Martijn, who will show you that the organizational form that this collective action took depended on whose health was perceived to be at stake in specific articulations of the public problem of infant mortality. And we will do so to argue, this is conjectural, and we really like to talk with you about that. What you think of this, that the historically specific shape of states can be understood thereby as the consequence of public health rather than as its starting point. So that's what we will be doing in this talk. Okay, how then did infant mortality come to be understood as a public problem around the turn of the 20th century? In our paper, we argued that this had a number of interlinking reasons. One of them being is that what happens in the second half of the 19th century in the Netherlands is what we call the medicalization of feeding newborns. In the mid 20th century still, so we've looked at, I think, Well, Sabina, I just learned reads Dutch, so she would be able to read it. But here it says de plichten der moeder, the duties of the mother in relation to the first physical and mental formations of the child. This was a textbook for mothers, young women and mothers in the mid-19th century. And this still very much emphasized at the time that the first and foremost duty of the mother, her natural disposition, was to feed her child. Also with that, if children then died, that was a natural thing that happened. It was her fault. But it was not something that was understood as something that could have been prevented. Prevented in the sense that a physician would have come in to do something about this, because this was very much within the realm of motherhood, and motherhood at the time in the Netherlands was not yet medicalized. You see similar developments because this then starts to change in the second half of the 19th century, early 20th century. Definitely in the United States, this has been something that has been investigated by historians like Rima Epple, who calls this a scientification of motherhood in this period. What starts happening is that in that period, so the time after this textbook, is that increasingly physicians start to understand, yes, mothers are responsible for their young babies, but they are also in and of themselves incapable of doing so. They need medical expertise to learn how to be a mother, to perform their natural duties well. And first and foremost, breastfeeding there was understood as the most important medical duty. Because also in this time, the dying of small babies was understood as a lack of breastfeeding. And also this was increasingly understood as a problem because in this period, not a lot of mothers breastfed. This had more than one reason. Sometimes if physicians were particularly cynical, they would say that they didn't do so, these mothers, because they were increasingly no longer, how do you say that, sturdy, that they were becoming weak in modern times out of modernity, so that their bodies could no longer handle it, or they were too bourgeois. They increasingly understood their breasts. And I'm sorry, always when I talk about breasts, I start instantly. Sorry, that just happens, but they talk about their breasts. Mostly in a romantic sense. They wanted to keep their breasts beautiful for their men, and they had forgotten that breasts were first and foremost to feed their children, so they didn't do so anymore. In reality, it was much likely that in this period a lot of women started working in factories and were thereby increasingly unable to breastfeed their child if they were also at work. But this was increasingly considered a problem. So what physicians also started doing in this period is they started, this had also to do with new developments in chemistry, but they started looking into how you could, the composition of breast milk, and they increasingly also tried to mimic breast milk by humanized cow milk, it came to be, but to change the chemical composition of cow milk in such a way, and also with Pasteur to sterilize it, that in case women did not breastfeed, then a lesser but still responsible alternative could be given. So that was one development. And with that also, the medicalization of feeding newborns, we argue, started having an effect of the way that the dying of infants was understood. The second thing, or the third thing that happened, was that in this period, a new medical specialty arose, namely paediatrics in the late 19th century, which was very closely linked also to 19th century developments in the field of statistics, collecting statistics. This happened with, I think that's also in the UK, the hygiene movement. I'm not sure if that was a term that was used in the Netherlands. This was called Egenis, sanitary reformers, which in the 19th century, especially in the second half of the 19th century, started collecting mortality statistics as indicators also of public health. There they also, when they differentiated between or within populations, they said how many children at the time died. They didn't yet look into infants, which for us is an important distinction. That only came later. So you had children, people under the age of 18, I think still, who died. This was not a goal in and of itself to collect that, but this information was also collected. This data was collected to look at, for example, in cities, whether certain airs were polluted, miasmatic. I think most of you know enough of history, what type of airs were polluting, etc. This data started to be collected, and indeed, as a consequence of the collection of this data, they started seeing that actually a lot of children died, and that maybe was a group, a population that started to come within view that needed extra attention. In 1902, that led also increasingly to this group of physicians who started then being concerned specifically with the health of these children, that led to the foundation of the Dutch Society of Paediatrics. But also, as a result of the collection of this data, they increasingly started seeing that maybe within the group of children, there was a specific group that was especially at risk, and that group came to be called infants, which is not a great translation, because in Dutch they are called suikelingen, which in English would be called sucklings. But that's not a term, because who are sucklings? Children under the age of 1, and namely those children that still ought to be breastfed. Because then in this period, the connection was made that if breastfeeding is considered a superior feed, and if a lot of children under the age of 1 are dying, then this group might be considered sucklings, children that could be prevented from dying if they would consistently be suckled, if they would consistently suckle. And this brought to use the words of hacking a new kind into being. Sucklings, which were considered a population that you could look into, and that how could you prevent then sucklings from dying by making them breastfeed? And in this period, by making these connections, infant mortality comes to be understood as a problem, that maybe so it's no longer about individual infants dying, but that's something a group, in this case pediatrics, pediatricians, can do something about. And also, and Martijn will explain this, it might be interesting also not so much to study them and prevent them from dying on an individual level, but on a collective level, because they're preventing from dying then starts to have other goals than just them being alive. And I think there, I will give it on to you.
Yeah. Well, yeah. So the health of these. Oh, sorry. Yeah. Thank you. Yeah. So the health of this population of infants starts to have consequences, or at least these infants are dying, start to have consequences for those not directly involved, so to speak, so the families themselves. And that also was made very clear by statisticians at the beginning of the 20th century, and local officials starting to worry about various groups of infants that were dying in their cities. They started to get involved in this debate that was started on by these pediatricians and sanitary reformers, and they started to think about or to map the correlation between the group of infants that were dying and classes or class and socioeconomic prosperity, and start to think about whether indeed there is an overlap in these populations. So that showed in this case by means of statistics, and that is also what was made very clear at the beginning of the 20th century by these statisticians in cities, that actually the infants from the lower class citizens were dying. And that became a problem because of the loss of labor capital within these cities, you had consequences not only for the mothers, which was of course very sad, but also for the labor capital and the workforce of that specific city. So in that sense, there's something needs to be done about that. And for that reason, in the beginning of the 20th century, Bernard Plantinga, that is this man over there, started to initiate these child health clinics that we discussed also this afternoon, to weigh babies in order to assess how healthy they were and what kind of nutrition they should receive. Primarily, they should be enabled or encouraged to breastfeed their children, but if that was not possible, then they should be provided with alternative nutrition. So in this sense, the first kind of activities to do something about infant mortality was undertaken by these wealthy citizens living in cities specifically, because they were worried about the loss of labor capital in the future. And that changed also because other, well, knowledge producers were starting to get involved. Sociologists, the early sociologists, anthropologists, and also political writers started to get concerned about infant mortality, but not necessarily for these socioeconomic reasons. It was not necessarily a socioeconomic problem, so to speak, but it became a national problem or a nationalistic problem, because these authors started to get concerned about infant mortality rates, or high infant mortality would be a threat to the nation. We also discussed this earlier this afternoon. Literally, they were phrasing this in terms that it is relevant, reducing infant mortality to the nation in view of its survival, so to speak. So there is a different population coming into view, not only of populations living in cities, so to speak, and these poor of infants that were part of poor families, but infants in a very general sense. It became an indicator of a Dutch population, of the Dutch nation. Infant mortality in this case became an indicator even of what's called national strength, and that is a literal translation of the notion of Volkskracht in Dutch. So that it could be used to assess the health and the strength, so to speak, of the Dutch population in comparison, indeed, to other countries. So what started to come up are these rankings. That's what you did. This is published by some of the organizations that were starting to do things about infant mortality. These first organizations started to initiate preventive child health care, started also to publish these rankings in which they could compare or rank the height of infant mortality in relation to other countries, which is something else than assessing infant mortality in these local cities. So this also that's also what you see here. And the Netherlands did, well, not that great. It also did not particularly well, but there was a concern that if it was nothing must be done about the health of the Dutch population being at stake, that it would be a problem to the nation and its survival, so to speak. And the first organizations trying to do something about it, that actually published these rankings, were not located in cities, but they tried to coordinate what was happening in these cities on a national level. They tried to centralize all these activities, so to speak. Also worried about this Dutch population. They failed in the Netherlands, at least in around the First World War. That is the context in which this was published, indeed. But at least there was this attempt to work on infant mortality and preventive child health care as a consequence on this national level. But the question became, how can we account for that, how the Netherlands is doing, so to speak, in comparison to these other countries? How should we sort of understand that? And well, perhaps ironically, they started to look and address this question not on a national level, as it was done in this case, but on a regional level. So to explain the position of the Netherlands in this case, these social medical reformers started to construct maps like this. This is also in the context of a bit after the First World War, in which they tried to compare various provinces, that are these black boundaries, to the Dutch average of infant mortality, and the municipalities, compare that to the Dutch average of infant mortality. And what it showed was that municipalities, specifically in the south of the Netherlands, had these higher infant mortality rates, which brought a new population into view, namely the Catholics living in this very region. So as a consequence of first trying to understand infant mortality on a national level. And that mobilized a new collective, you could say. These clerical leadership started to get involved, and charities with a religious motivation started to get involved in infant mortality in the 1920s for a big part, because they were worried about the future of specific religious groups in specifically the Dutch South. So these new organizations, cross societies, modeled after the Red Cross in peacetime eras, and then with a very religious connotation, started to organize preventive child health care to do something about infant mortality, not necessarily on a national level or in cities, but in the Dutch South. And what happened as a consequence of that these religious organizations also required funding, whereas these organizations in cities were very dependent on wealthy citizens providing money to these organizations. These religious organizations worked on a regional level, also went to the Dutch government, the Dutch central government, so to speak, and asked them to fund their activities. And it was also the result because, well, a lot of activities were already happening in the middle of the Netherlands and a bit in the north of the Netherlands, but not that much in the south of the Netherlands. So from the government's perspective, and then I'm talking about the national government's perspective, the reason for funding these Catholic charities was to compensate for the low degree of activity in the south of the Netherlands. So the reason why the Dutch national government got involved was not necessarily because they were worried about the Dutch population, so to speak, or the national strength, but really to help the Catholic organizations, the religious organizations, to also participate in this collective action. So these Dutch parliamentarians worried over fair and regional distribution of national funding. And they called it an unjust system. It was not really a system because it was not designed as such, or it was a very clear principle behind these activities. But the way it was organized was at least considered as unfair. And as a result of that, the Dutch government started in 1927, started to come up with a draft system. In that sense, it was really called a system in which local organizations were encouraged to collaborate on a regional level, and if they did so, according to how the government or the Dutch government envisioned that, they were partially funded by the Dutch government. So for 2/3, the pediatricians and salaries of the pediatricians were funded. And the other third, which is I think rather important, came still from these religious or liberal or well this amalgam of organizations that self-funded these activities. And this map that we constructed shows the kind of the organizational background of all these child health clinics. For those who also attended the earlier session maybe recognize this map. This one is Polish, which is also nice. So the green dots represent Protestant organizations. The yellow ones represent Catholic organizations. The blue ones represent liberal or neutral organizations, and then the white ones represent governmental organizations. And governmental then was not the national government, but local municipal governments started to get involved. So what happened in 1927 is that the institutionalization of a division of labor came into being, or an institutionalization. I'm phrasing it wrong. So there is an institutionalization of a division of labor between these governmental bodies, and on the one hand, who funded the activities of these civil efforts, and that is quite interesting, I think, from also various perspectives. So, as a matter of conclusion, so for public health ethics, this is an interesting story because at least it shows. That's also what we should at least what this map at least shows, is that public health, or in that sense defined as collective action in relation to this population, came into being as without this national government coordinating these activities. And from the perspective of public health ethics, that can be interesting to think about what consequences that can have, because much public health ethics, for example, about vaccination, but also other dilemmas involved, very much focus on the legitimacy of governmental interference. And if we think about how public health and collective action can come into being without sort of this government being very much involved, or at least only in the second instance, what kind of new questions come up as a result of that? So how can we think about public health and whether or not that is legitimate, if we do not assume or presume that the national government should have a very important role in that as a question? And then for the historiography of public health, so the similar sort of questions pop up. So Dorothy Porter, that's also why indeed this is useful, defines public health not as a state intervention, so to speak, but as collective action in relation to the health populations. And well, perhaps ironically, she uses that to study the relationship between public health and state bureaucracy, but we can also think more critically, I think, what specifically is a state in this case? Is that the national government, or is it local governments, or is it a combination of all these governments, and specifically in a Dutch context? So in that case, the question becomes for historians, so can we write the history of public health without these governments that are playing such a central role? And then the question becomes, how does collective action, how does doing things together come into being? So for anthropologists, and this is something that I'm really thinking about, this is actually not a part of the paper that we published, but it is something that fascinates me, is specifically the work of James Ferguson, who really thought about the relationship between the state, so to speak, and civil society, if you think about social change. So how can we change society? Then, according to Ferguson, there are basically in anthropology, but this is also a bit of an old paper at the end of the 20th century, he identified basically two answers to that. On the one hand, social change, specifically in foreign areas, is perceived as nation building, as a state that is strong, tries to effectuate to change the local communities, so to speak. And on the other hand, there is that implies then that social change happens top down, so to speak. And then the other answer is focused on state and society relationships, in which, well, there is a very much a lot of criticism on the state as indeed this well, way too powerful institution, but instead focuses on tribal communities as these pure communities that should be valued in the context of social change. And change actually happens bottom up. And what they propose is, or they, at least, or Ferguson, how it critically relates to that, is he states, and I find this very attractive myself, that he assumes a vertical topography, as he calls it, between the state being out there somewhere, whatever that specifically means, doing something to local communities on the one hand. But in the other case, it is actually the same. If we focus on these local communities that are actually should be the root of social change, then we assume that change happens from below, from the local to the national. And what he proposes is a horizontal typography of how governments or the state actors collaborate with civil society, with civil organizations. And then we should think about governmental interference and maybe also about social change as having a codependent relationship with these civil collectives. So then the question is not necessarily about what kind of institutional body is specifically taking the lead in social change, but how in very specific local contexts are various collectives in which both governmental actors and non-governmental actors are collaborating and not really analytically at least, but also empirically, not really be distinguished. And so this is based on anthropology, but what I think at least that our paper does or can do potentially is offer an historical example of how indeed these collectives come into being. And what we have to add then to that kind of literature is the role of public problems, of perception, so to speak, or collective perception plays in building these collectives, so to speak. So that then is a more pragmatist take on public health, and indeed that was inspired by John Dewey, and that social reality then is the consequence of understanding or of perception in this case, and we try to tie that to collective action in relation to the health of populations. So here, the role of public problems in mobilizing and uniting actors into political communities that are undertaking these collective activities is important. And what we try to do is to show that different problem definitions, and then a public problem defined as a problem at which the consequences are perceived as being relevant to those not directly involved. That is then the distinction we make between individual or private and public sphere. How that also has a consequence for what kind of activities are coming into being. So then the states can potentially be perceived, at least descriptively, as a consequence of this pre-existing social activity. So Dewey's state emerged then on the domain of child health care as the organization of the public, in the end, effect through officials for the protection of the interest shared by these members, so that these pediatricians became these public officials. So, as conclusion then, we have, I think, 4 conclusions, maybe more at least, but analytically that is at least something that we can talk about. That populations can also be perceived as or be analyzed as the consequence of problem definition. So various perceptions of instrumentality, and for amplifying then the socioeconomic, national, regional, religious dimensions are made visible in a different way, but different yet overlapping populations, so to speak. And then secondly, political communities can also be seen as the consequence of the articulation of these populations at which their health is at risk. So different political communities taking interest in the health of different populations, so to speak, and they were mobilized in collective action in relation to instrumentality. And thirdly, the shape of the state was, and can be, the consequence of pre-existing collective action. So the Dutch state, in this case, took shape when the national government participated in preventive child health care to coordinate these pre-existing activities. And this stabilized also division of labor between these civil organizations and governments that would also characterize the Dutch welfare state in the rest of the 20th century. And we fourthly think that it is helpful to think about public health with attention then to the historical process of defining public problems or public issues. And that's it.
You guys want to CQ?